This PowerPoint presentation will discuss the condition of osteogenesis imperfecta, also known as OI. The condition's etiology, mechanism by which it affects development, and the impact it has on body structure, function, and occupational performance will be discussed. Common assessments used with this population, as well as intervention strategies, will be considered. In addition, we will cover pertinent information such as precautions when handling those with OI.
Okay, I'm going to talk a little bit about the etiology of this condition. So this is a genetic disorder where bones break very easily. It's also called brittle bone disease because of this. The term osteogenesis imperfecta literally means bone that is imperfectly made from the beginning of life. This is caused when a gene malfunctions or there's a collagen gene mutation. This affects how we make collagen, either too little or it's very poor quality, and it leads to deficiency of type 1 collagen. Again, collagen is the protein that helps make our bones strong, so that's why this is brittle bone disease. It's usually diagnosed during prenatal ultrasound at 18 to 24 weeks of pregnancy. Diagnosed through medical and family history, physical and imaging or lab tests. If it's hereditary, DNA can be tested for an osteogenesis imperfecta mutation. If it's not detected prenatally, symptoms can present in a child that a doctor can test. The first indicator of this is broken bones that occur from little to no trauma. Approximately 1 in 10,000 children are diagnosed with osteogenesis imperfecta, and there is no cure for it. So individuals with osteogenesis imperfecta are born with defective connective tissue. If a parent or sibling has it, the DNA of the fetus can often be tested for mutations. The tests by the physician include a physical exam, measuring the length of the limbs, head circumference, examining their eyes, teeth and spine for any curvatures, and the rib cage as well. Questions about personal and family medical history, about broken bones, hearing loss, brittle teeth, adult height, and even different races. It does occur equally among males and females and different racial groups. That doesn't make a difference. I'm going to talk about the impact on development. So osteogenesis imperfecta can cause muscle weakness, loose joints, brittle teeth, as I discussed previously, a curved spine, and even hearing loss. There are 6 different types of it. They range from mild to severe, and symptoms can vary for each person. So no one person will have the same exact symptoms. These individuals will experience frequent broken bones from infancy through puberty, and the frequency typically decreases in young adulthood or young adult years, but it could increase again later on in life. There are often delays in motor skill development in children due to the osteogenesis imperfecta related muscle weakness, and it is a congenital bone disorder. Some other common comorbidities or conditions include respiratory problems like asthma, short stature, distinctive skull features, cardiac issues, fatigue, and skin, blood vessels, and internal organs could even be fragile. All patients, doesn't matter which ones, but any that have osteogenesis imperfecta will have fragile bones. In more mild cases, the individual might only have a few fractures throughout his or her life, but in the more severe cases, they can have hundreds of fractures that might occur without any apparent cause or reason. Some individuals with the more severe type might have very severe respiratory problems, either in infancy or childhood, and some might even require supplemental oxygen. Some further information about the co-occurring issues. I already talked about the spine curvature, the bone deformities. There can also be bone pain associated with that, loose joints, muscle weakness, the skull deformities, like late closing fontanelles, a larger head circumference, more than average. About 50% of osteogenesis imperfecta patients by middle age will have some type of hearing loss and vision problems. With good medical management and supportive care, the majority of people with osteogenesis imperfecta will lead healthy and productive lives and also an average lifespan. More about impact on body structures and function as far as neuromusculoskeletal functions. I already kind of mentioned the joint instability and the muscle weakness. Furthermore, sensory functions with the hearing loss and visual acuity impairments. This includes sclera, which is when the whites of the eyes usually have a blue, purple, or gray tint to them. And then bone pain, respiratory and cardiovascular functions I touched on as well. And the possibility of the respiratory problems could be due to the barrel-shaped rib cage.
An article found showed the impact of osteogenesis imperfecta on occupational performance, not only for the young patients, but also their families. Dogba et al. Conducted a temporal analysis of the impact of this condition in young patients with OI and their parents. This study took place at the Shriners Hospital for Children in Montreal, Canada. Semi-structured interviews were conducted for 24 subjects. 12 young patients diagnosed with severe OI and 12 of their parents. Interviews were subject to inductive open thematic analysis and a temporal comparative analysis. A retrospective chart review was utilized to complement the data collection. Results showed consistent reports on the negative aspects of this condition and how much change and accommodations had to be made for the children and their families. 4 overall themes were also mentioned from the study, including 1. Starting at the time of diagnosis, a series of stages shaped life. 2. Living with OI was full of ups and downs throughout life. 3. Every day, normal life with OI consisted of significant changes for parents and challenges for the whole family. And 4. Living with OI generated some positive experiences. Some of the specific negative attributes identified in the study from personal experiences from either parents, the young patients with OI, or both groups of participants included mobility, community participation, role change, play, social participation, and ADL-IDLs. Specifically, for mobility, some of the concerns address the limited ability to walk. Most parents express fear that giving the child the freedom to walk would increase the chance for falling. As for community participation and integration, the young patients with OI stated that most classmates would not give an opportunity to speak with them because of judgment of appearance. Furthermore, the young patients and parents both mentioned that going on trips had to be heavily adjusted or put off because of not wanting to leave the child behind. They could also not find the means to include them in activities. Social participation is similar to community participation in that judgment from classmates decreased the ability to make friends and become a part of something. When it came to concerns of role change, this was more geared towards parents and siblings. Parents stated across the board that there was caregiver strain because of taking on more roles and tasks was largely necessary to support the family and child. Some of these changes included taking on more jobs, increased finances, home modifications, moving to accessible homes, quitting jobs to stay at home as a result of lack of trust in others caring for the child, otherwise babysitters, and sacrificing vacations and social time for the child. Siblings, as mentioned by the parents, had to give up those vacations as well. Play was limited by the parents because of the overall fear of getting hurt during outdoor activities. ADL and IDLs, above all else, was a key issue because of the inability to do things independently, which then fell back on the family. Nevertheless, some positive aspects came from this, such as the emotionally rewarding experiences like developing a positive mindset or putting things in perspective and living one day at a time and expecting that the next day would get better. Some limitations to the study included purposeful selection of severely affected patients, limiting generalization of conclusions to other patients. There was no quantitative measure of financial loss or impaired quality of life associated with OI. And finally, the sample size could have limited an exhaustive exploration of the impact of severe OI. The article concluded by stating that living with a diagnosis of severe OI can be heartbreaking for parents. However, most of them eventually redefine life, creating a new normal life, characterized by ups and downs, challenges and change, but also building positive experiences. The researchers also mentioned that patients with severe OI also face many challenges, but tend to develop a positive mindset. The findings uncovered a number of particular support needs and suggests to readers that the needs would be most met by an, in quote, tailored life span and family-centered support system delivered through specialized genetic disease centers.
Here are some assessments to use when evaluating a child with osteogenesis imperfecta. The PDMS-2 assesses ages birth to 5 years. It evaluates gross and fine motor skills of children, including areas such as joint mobility and stability, muscle power, tone and endurance, motor reflexes, gait, and voluntary movement control. The SFA assesses grades K through 6, and it evaluates a child's performance of functional tasks that support his or her participation in the academic and social aspects of grades K through 6, including areas such as social participation, play, ADLs and IADLs, and education. The MFON assesses ages 2.6 to 7.11 years, and it evaluates potential developmental delays in fine, gross, and visual motor. The COPM gathers information regarding the client and family goals related to function to learn their strengths, interests, and barriers to occupations. Manual muscle tests and range of motion assesses strength and ranges of motion related to functional tasks such as dressing, grooming, and feeding. You can also use the Borg numerical pain scale or other age-appropriate pain scales to assess pain. Visual acuity assessments, because some patients present with myopia and are at risk for retinal detachment. Other hearing assessments are important because over 50% of people with OI present with hearing deficits or loss. And finally, environmental assessments to promote accessibility within the home or school context. And these can be used to suggest adaptive equipment or environmental adaptations to promote optimal performance in the home or other contexts.
There are a variety of different treatment options for those with OI, both non-invasive and invasive. Treatment should be directed towards preventing and controlling the symptoms, maximizing independent mobility, and developing optimal bone mass and muscle strength. Those with OI benefit from living a healthy lifestyle that consists of safe exercise and a nutritious diet. This diet may include adequate intake of nutrients such as calcium and vitamin D, as they are crucial to maintain bone health. Exercise also prevents fractures, specifically using swimming as a therapeutic tool to promote muscle and bone strength. Those with OI should avoid activities such as smoking, excessive alcohol and caffeine consumption, and taking steroids as they deplete bone density and exacerbate bone fragility. Adaptive devices can be considered with those with OI, such as wheelchairs, walkers, braces, and hearing aids. Additional modifications may include crowns for their teeth and supplemental oxygen for respiratory issues. Medications can include growth hormones and gene therapy, as well as those for pain management. Bisphosphonates is a class of drug that prevents the loss of bone density by inhibiting osteoclasts and is very effective in treating OI. Surgical procedures such as rodding is used to prevent or correct bone deformities and strengthen the bones by inserting a rod into the long bones. Other surgical procedures include correction of bone deformities, spine stabilization, and surgery to the small bones in the middle ear to improve hearing.
OTs often work with an interdisciplinary team, including physical therapists, orthopedists, and orthotic specialists when working with clients with OI. OTs offer their unique input through interventions such as protective positioning and protected movement. Protective positioning is an intervention that is particularly important for clients with a more severe form of OI that limits their mobility. OTs provide caregiver education and demonstrations on how to position clients throughout the day to facilitate proper bone growth, strengthen muscle groups, and prevent contractures. Protected movement involves performing an activity analysis of a client's current level of mobility and then providing graded practice at improving their movement patterns and acquiring skills such as rolling over, sitting up, and transferring to standing, depending on their ability. This intervention also works to address clients' fear of movement, which commonly presents with OI. Fractures are very traumatic and clients are often fearful of them recurring. The graded approach of protected movement helps clients to overcome this fear and maximize participation. OTs can also recommend a number of adaptive techniques and devices to address occupational challenges. Energy conservation can be addressed by creating stations around the home, such as self-care stations, homework stations, and kitchen stations, where all of the necessary tools are in one place to prevent unnecessary trips around the home. Joint protection can also be addressed through devices such as reachers and shallow drawers or shelves to limit the amount of reaching needed to complete home care tasks. OTs can assess clients' mobility needs and recommend appropriate mobility devices to maximize participation in clients' occupations. The client's home, school, or work environments are also assessed to ensure accessibility and a proper fit of the mobility device. Clients with OI experience fractures throughout the lifetime, so OTs can fabricate orthoses that facilitate proper bone growth and muscle healing and prevent contractures. Treatments for OI are unable to reverse or cure the effects of the condition, so the main goal is to maximize clients' participation in their meaningful activities and roles.
In addition, we have included some precautions to take when caring for people with OI. In general, you never want to pull or push on a limb or bend it into an awkward position, not even to take an x-ray. You want to use caution when inserting IVs, taking blood pressure, or performing other medical procedures to avoid causing injury. Always dose medicines to the size and not the age of short-statured adults. When a fracture is suspected, you want to minimize handling of the affected limb. Respect the opinions, advice, or instructions provided by parents, children, and adults with OI. Based on experience, they give good directions for the safest ways to lift, carry, or reposition. Having dealt with dozens of fractures and medical procedures, even children have a good sense of when a bone is broken even before x-rays are taken. Special precautions to take with babies and children. You want to lift a baby with OI by placing one hand under the butt and legs and the other hand under the shoulders, neck, and head. Do not lift the baby from under the armpits. Do not lift by the ankles to change a diaper. Rather, slide a hand under the buttocks. Babies do not need to be kept on a pillow or soft surface. Encourage babies to explore independent movement. Supporting infants in a variety of positions, for example, side lying or stomach lying, develops muscles that will help with sitting and standing later on. And that's all for the precautions.